There is no pallor, cyanosis, icterus, clubbing, edema, or generalized lymphadenopathy. Neck nodes, including the supraclavicular nodes, are not enlarged. These are the clinical pictures. In the local examination inspection, a 4 into 5 centimeter swelling is seen in the right parotid region in front and below the right ear lobule. The skin over the swelling is normal, with no obvious evidence of facial nerve palsy. No swelling is noted in the neck region. Oral cavity examination, there is slight bulge in the right tonsillar fossa, but there is no deviation of the uvula. Contralateral parotid region is normal. Scalp examination is normal. On palpation, skin over the swelling is not warm. There is no tenderness over the swelling. A single 4 into 5 centimeter swelling is palpated in the right parotid region in front and below the ear lobule. The swelling has a smooth surface, hard in consistency, and well-defined border. It is extending superiorly up to the level of tragus, inferiorly just below the angle of mandible, posteriorly just behind the ear lobule, and anteriorly 3 centimeters from the ear lobule. It is not mobile, relatively fixed. Skin over the swelling was normal and pinchable. There is no signs of facial nerve palsy. On oral examination, on manual palpation, the deep lobe of the right parotid gland is palpable. Contralateral parotid region was normal. Right external auditory canal examination was normal. Other system examination was normal. In summary, a 63-year-old male with painless swelling in the right parotid region with no signs of facial nerve palsy. On examination, 4 into 5 centimeter firm, hard, non-mobile swelling is palpated in front and below of the right ear lobule, which is fixed to the underlying structure with well-defined margins and pinchable overlying skin and palpable deep lobe during bimanual examination. There are no signs of facial nerve palsy or cervical lymphadenopathy. So my working diagnosis is malignant right parotid tumor, stage C T3N0M.
Okay, Sandeep, you said that swelling is not there in the neck.
Yes, sir.
Then in the examination, you said that swelling is behind the angle of the mandible. So
No,
what
the right
structure lies
side.
behind the
Yes.
angle of the mandible?
What behind angle of mandible there is sternocleidomastoid.
Which part of the neck comes under behind the angle of the mandible? You said that the swelling is not in the neck, and then in the examination, you are saying that the swelling is in the neck. Level 2B.
Actually, sir, the swelling is in the front of the tragus and in the front of the tragus and the ear lobule and below the ear lobule. It is the swelling is extending in behind the ear lobule, but there is no separate swelling in the behind the angle of mandible.
So the swelling is in the parotid area, or is it in the neck?
No, sir, it is in 100. It is in the parotid area.
Do you have a profile picture of the patient?
Profile.
Side profile. What is the classical feature which is not seen in this profile that should have been there to call it a parotid swelling?
The ear lobule should be more pushed upwards. One.
Upwards.
But it is lifted.
Yes, sir, it is lifted.
It is lifted in the lying down position with neck extended, but not in the profile. See, the picture on the right is a operative picture that is taken at the table. Chalo.
So why do you say it is a malignant tumor?
Ma'am, there is very short history, 1 month old history. First, second, there is the mass is hard and it is relatively fixed, and also I can also palpate the deep lobe. So,
So
according
deep lobe, there can be lesions arising
yes, ma'am.
only in the
Yes, ma'am.
deep
Yes,
lobe.
yes, ma'am.
That
Yes, ma'am. But I'm including all three, including all three points. I'm getting into the picture that this is a malignant swelling, not a benign swelling. Short duration of history. One more point. Patient is elderly male. Patient is a 63-year-old male. Elderly patients have more propensity to develop the malignant lesion. Benign lesions, the median age group is 40 years. 60 years,
but should include deep lobe is palpable in your findings. It's a hard swelling, short history, and elderly male. So how will you investigate him?
now, uh, now, now I'll go for MRI right parotid with neck, along with FNAC, along with FNOC of the right parotid gland, along with some blood investigations, X-ray and ECG. The FNAC came as a high-grade mucoepidermoid carcinoma, and MRI. This is the MRI picture. This is a T1 weighted image. This is the T1 weighted image. This is the superficial lobe. This is the deep lobe. It is the swelling is 5.5 into 5.2 into 3.4 centimeter, involving that. This is a T2 evaded image involving the deep lobe of the parotid gland, which is extending, which is also involving the superficial lobe, and also it is pushing the it is in the parapharyngeal space. Along with it is pushing the tonsillar fossa to the in the mouth. That is palpable. And in the next picture, I can see the one lymph node which is enhanced. This is 1 centimeter lymph node in the level 2, which was clinically not palpable, but it was seen in the MRI picture.
So
So
what else is to be seen in the lesions which involve the deep lobe and push the tonsil out?
yes, sir. First, the facial the structures the in the MRI picture which involves the deep lobe, we have to see the flow of the we have to see the vessels, veins, retromandibular vein, and the external carotid artery, whether it is involved or not. Whether
Why
it
do
is
you want to
involved,
see a retromandibular vein? You can always ligate it.
yes, sir, I can always negate it. Yes, sir.
So what you should be seeing,
Next, the facial nerve. Facial nerve is involvement.
that is
Facial
clinical, that you are not going to see on MRI.
Usually the deep lobe is in the pre-styloid space of the para, uh, parapharyngeal space. It doesn't go in the post-styloid space.
What is the relation of internal carotid with tonsil?
Internal carotid artery travels in the post-styloid space along with the cranial nerves 9, 10, 11, 12.
What is its relation with the
Posterior to the posterior tonsillar pillar in the parapharyngeal space.
So what happens when your tumor is pushing the tonsil out and reaching up to the lateral pharyngeal wall?
It can involve the internal carotid artery.
So can you show me where your internal carotid artery is? And also show me that your deep lobe is lying in the pre-styloid compartment. What divides superficial and deep lobe, pre-styloid and post-styloid? So
Stylo,
what is
stylo,
dividing it?
stylopharyngeal membrane or stylopharyngeal raphe. You know,
Ooh.
tensor valley the there is a there is a ligament, sir, which joins the styloid process to the, sir, pharyngeal muscles, stylopharyngeal muscles, tensor valley palatini. This divides the pre-styloid and post-styloid space, sir.
So show me on a MRI. Where is internal carotid artery? On the normal side and disease side. No vessels are seen in this picture.
This is internal carotid artery on the disease side.
Where? Can you put your cursor on it?
Yes.
So what are the requirements of getting an MRI when you are planning a parotid? What kind of MRI you should be ordering? So where is the contrast enhanced MRI? Show me the contrast enhanced MRI. Show me the vessels. Because next step you are going to say that you are going to do surgery. Before you go in for a parotid, you should know where your vessels lying.
Sir, actually, this patient came with this MRI, sir. We didn't order a contrast enhanced MRI. Patient came with this MRI outside the hospital.
You are happy with it.
No, sir, I'm not happy with it. But I should have ordered the contrast enhanced MRI to know the relationship between the vessels.
Suppose this patient presented with pain.
Yes, ma'am.
What could have been the reasons?
Ma'am, pain involves the pain means there is a malignant tumor first. Second, there is rapid increase in the size, which leads to internal necrosis and stretching of the capsule, and this also causes a pain.
And if this was an adenoid cystic advanced parotid tumor, where all it could travel. And secondly, when you say MRI, I think the better terminology would be from skull base to thoracic inlet instead of only parotid and neck. Thoracic inlet, yes. So tell me, where all can tumor travel,
Ma'am,
especially like
adenoid
adenoid
cystic
cystic.
carcinoma, ma'am, has the more affinity to the nerves. It shows the perineural invasion, and it can travel with through the nerves into the till the skull base.
Where
So
in skull base?
it can go through. It can travel through the. It can travel. It can involve the facial nerve. Facial nerve can go into that stallomandibular foramen and then into the skull base.
No, where in skull base? What is skull base? What are the foramens there? And are they important?
Yes, ma'am. Uh, they are important, ma'am, in the parotid surgery. Stallomandibular foramen and
Only stylomandibular पे ही अटके हुए हो. We are talking about skull base. What is the nerve supply of parotid?
auriculotemporal nerve, ma'am.
You
Auriculotemporal.
you trace the pathway right from medulla oblongata, both
Yes, ma'am. Yes, ma'am. Yes,
parasympathetic
ma'am.
and
I can do
sympathetic.
that. I can do that, ma'am.
So
Yes,
tell me,
yes, yes, ma'am. Inferior salivary nucleus. Then
where is
from
it?
gloss, inferior salivary nucleus in the medulla.
Okay, then
Then glossopharyngeal nerve. Then glossopharyngeal nerve, the tympanic
so
branch.
where does this glossopharyngeal nerve exit from the brain? What is that foramen? Jugular foramen. Then what happens?
Jugular foramen. Then, ma'am, tympanic branch. Then it goes to tympanic plexus. Then it comes to the inferior petrosal nerve. Then
Inferior or lesser petrosal nerve?
lesser petrosal nerve. Lesser petrosal nerve. Lesser
Then
petrosal nerve. Then it goes to uti ganglion, and then
no, where does it travel? There is I'm telling you because you must know these foramens. The tumor can travel right into the brain. Advanced disease. Superficially, it will look just what is it in your patient. So this lesser petrosal nerve, it comes out through which foramen? It's the foramen ovale, and then right below foramen ovale lies your otic ganglion. So these are preganglionic fibers or postganglionic
these are
fibers.
preganglionic fibers, ma'am. Before uti ganglion, these are all preganglionic fibers.
So this is parasympathetic.
Yes,
Then it synapses and postganglionic fibers from otic
auriculotemporal nerve.
travel through auricular. What is which auriculotemporal is a branch of?
Uh, uh, Auriculotemporal is a postganglion. It is a postganglionic parasympathetic branch.
No, it's not parasympathetic. Parasympathetic fibers are traveling along with that nerve. Mandibular nerve.
Mandibular division of
So mandibular is a branch of
trigeminal
which
nerve.
nerve?
Trigeminal nerve, ma'am. Trigeminal nerve. Mandibular division of trigeminal nerve.
And what is the sympathetic supply of parotid?
So
Sandeep, what are the when will you suspect how will you evaluate facial nerve or MRI? Like where will you look for facial nerve? I know you can't exactly see the facial nerve, but what will you look for likely involvement of facial nerve on MRI?
thickened, thickened rounded thick structure between the superficial and deep lobe.
Rounded structure between superficial and deep lobe. Have you ever seen it?
So where do you find it, Tarun? Tell us.
It's a broadening or it's a widening of stylomastoid foramen, where you should suspect for involvement of facial nerve.
Okay, proceed please, because you have limited time.
So my final diagnosis will be high-grade mucoepidermoid carcinoma, stage C, clinical T3, N1, M0. So now I will counsel the patient regarding the surgery. So first I will tell the complications of surgery, like facial nerve, temporary facial nerve palsy, greater auricular nerve palsy, greater auricular nerve paralysis. Next, I will also consult the patient regarding the regarding the need for post-operative RT, and also regarding the recurrences. After
So,
that,
so this means you are planning to do a radical conservative parotidectomy. Why?
yes,
Why?
because sir, facial nerve is clinically not involved, and in any case when the facial nerve is clinically not involved, we have to preserve the facial nerve.
Listening.
Proceed, please.
After counseling the patient, I will go for total conservative right paratectomy with lymph node dissection, right cervical level 1, 2, 3, 4, 5.
Why do you want to dissect level 1?
Sir, since level 2 lymph node are enlarged, and enlarged, and it seems involved, so I will go for complete lymph node dissection right from level 1 to level. So finally, in the operating after the or pre-anesthetic checkup, I will keep the patient in the operating operation theater, and with the under general anesthesia, I will keep the patient in the neck extended position and head turned towards the opposite side, and I'll put up a cis trunk incision or modified Bayer's incision or a radius step incision, and I'll raise the flap along with in the subplatysmal plane, and after that, after raising the flap, I'll dissect the digastric posterior belly of digastric muscle. I'll also dissect sternocleidomastoid muscle, and also I'll see for the tragal pointer. The facial nerve lies 1 centimeter below, deep and inferior to the tragal pointer, and also after
What are the
merging
other methods of identifying facial nerve
yes, sir.
other than tragal pointer?
Yes, sir. First is the tragal pointer. Second is the posterior belly of digastric lies just 1 centimeter above the facial nerve. So third is
At what point? Posterior belly of digastric is quite long.
at its insertion. At its insertion.
Okay.
Yes. Third is uh, tympanomastoid suture line, which is the most consistent anatomical landmark. Tympanomastoid suture line.
Where do you
Fourth
see
is,
it during surgery? Tympanomastoid suture line.
uh, 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 during surgery, sir, when we during at the tragus at the tragus point incision, I will retract the parotid gland medially, and I'll see for the tympanomastoid suture line in that area. And after that, I'll go for after these three I can also go for retrograde trace of the, like, first I trace for maxillomandibular nerve and go backwards, and even if all these are not fruitful for identifying the facial nerve, then I can drill for the mastoid and then can search for the facial nerve.
You've missed out one of the ways.
Yes, sir. Styloid ligament. Styloid ligament. No, styloid ligament.
Stylomastoid foramen. So you can palpate the mastoid, you can palpate the styloid. It's in between the two.
After identifying the nerve, I will dissect along the nerve. There are two major trunks, temporofacial and cervicofacial. I'll try to preserve all the facial branches and try to dissect the first superficial lobe. And after dissecting the superficial lobe, I'll loop the all facial branches, facial nerve trunk along with all its branches, and then.
Will you preserve the greater auricular nerve?
Yes, ma'am. I'll try to preserve the greater auricular nerve.
So what happens if it is transected?
Ma'am, if it is transected, the ear lobule, the sensation over the ear lobule and posterior auricular area is lost. It is troublesome in the females because they can't feel the earrings ear in the lobule, so they can't wear the earrings without.
Okay. Proceed.
After identifying all the facial branches, I'll dissect off the deep lobe, and I'll remove the specimen and close the. I'll secure the hemostasis and I'll put a drain, and then.
What about lymph node dissection? You said you'll do 1 to 5.
Yes, sir. Yes, sir. And second, the lymph node dissection also. Yes.
How will you do it from a cis trunk incision 1 to 5?
I'll
said you'll keep a cis trunk incision, right?
Yes, sir.
Or
I'll give a second incision in the neck, McPhee second McPhee type incision.
McPhee?
Not McPhee, sir. A second incision in the neck, 2 centimeter, 2 finger above the clavicle.
You will not be able to do.
Will you be able to approach 1A from this incision?
I'll have to. The neck incision will have to be extended. The neck incision will have to be extended. Then I will reach the first level 1A.
Okay, go ahead.
So what are the complications of a parotid surgery? Start from intraoperative.
Yes, sir. Intraoperatively, there could be a transaction of the facial nerve, or if it, or there could be a blood loss, bleeding during the operation. Postoperatively, there is uh, immediate facial nerve paralysis. A long term is a complete facial nerve paralysis. Then Frey's syndrome, that is gustatory sweating. And if we remove the deep lobe, then there is a syndrome called first bite syndrome. This can also develop.
Flap
Sure.
necrosis, parotid
Flap-
fistula,
Parotid,
psilocele.
yes,
Who
yes,
will
ma'am.
tell that?
Yes, ma'am. Parotid fistula can also be there. Flap necrosis can, if the flap is thin, then there is flap necrosis could be there.
In this case, if you have to sacrifice the facial nerve because it is engulfed from all the side by tumor, even though clinically not involved, will you still call it a complication?
This won't be called a complication because we know we know the nerve is involved and we are transecting it. But will try to put a graft for nerve graft for this.
So, what is the choice in the periphery where you can use a nerve for a
And
graft?
great auricular nerve is the first choice because it's the same incision field. Second, I can use a hypoglossal nerve. Third, I can go for sural nerve. Uh, One more is coming, that is mesenteric nerve graft.
So,
And
what is the important thing to remember when you are planning? First of all, you will call a plastic surgeon, I'm sure. But still, what is the basic principle of joining the two nerves together? How many types of endoneurium, perineurium, epineurium, how are they distributed in a nerve, to say the least? So, if you have a nerve, what will you stitch?
What are the kind of nerve repairs you know of?
usually we stitch the perineurium only.
No, no. So, what is an epineurium, perineurium, endoneurium? Tell their anatomy. Have a nerve. The nerve is composed of a large number of axons, right?
Yes, ma'am.
And these axons are bunched together as fascicles. And then a number of fascicles together form a nerve. Now I've simplified it for you. Tell me.
Ma'am, perineurium is the outermost layer.
No, that is epineurium. So perineurium goes around the fascicles and endoneurium around the axons. So once you stitch, you should try not to disturb the perineurium. The epineurium is attached. What suture will you use? Yeah, rather is used even if you don't use.
10 0 nylon. Ma'am, the regeneration of postganglionic parasympathetic branches of the auriculotemporal nerve to to the to the sympathetic branches of the sebaceous glands of the not sebaceous glands of the
Sympathetic, no, what sebaceous you are talking? Sympathetic cholinergic
sweat
fibers.
glands. Yes, ma'am, sweat
Huh.
glands. Yes. Sympathetic
So
cholinergic
how
glands.
will you test it?
Ma'am, for testing it, first we put a iodide solution over the temple area, over the
So
parotid
what is
area.
that test called?
Starch iodine test.
Minor test is another name. And how it is treated quickly?
Ma'am, it is first and foremost thing is the reassurance. Second is the
If I ask you only one intraop, no, patient has
Botox incision. Botox incision.
but
Botox
how
incision.
does this Botox help here?
Actually, ma'am, it kills the aberrant regeneration.
No,
Regenerating the
no, it's not a toxin. It's used in facelifts also. Toxin injections. What's the how does it work? You have not read. You please read it.
Sandeep,
Okay.
one more question. Suppose we don't have a facility of, the plastic surgeon is not available and you have to transect the facial nerve.
Yes.
Will you do any additional procedure along with parotidectomy?
Yes, sir. Yes, sir. I'll go for a lateral tarsorrhaphy.
Okay. And what if in this case the final histopathology is squamous cell carcinoma? You said FNAC was poorly differentiated mucoepidermoid,
Yes, sir.
which could very well be a poorly differentiated squamous cell carcinoma, which you will not be able to differentiate on FNAC. So now in post-operative histopathology, if this is squamous cell carcinoma, now how will you go ahead with the management?
I'll send the patient for postoperative RT.
That the patient is anyway going. Anything else?
Final histopathology was squamous cell.
No, sir. Patient was operated a few days back.
Okay, you have not received it. Okay.